Welcome everyone to today's webinar. I am Emma Goodman with Becker's Hospital Review. We will begin today's webinar with a presentation, and we will have time at the end of the hour for a question and answer session. We are pleased to have Scott Becker, publisher of Becker's Healthcare, here to moderate today's question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter Question for Staff and clicking Send. We're looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, I want to thank our sponsor for today's webinar, Change Healthcare, and introduce our presenter. Erica Thorson has been with Group Health Cooperative for Eau Claire for 9 years. For the past 3 years, she has managed the Quality Improvement Department, and prior to this, she supervised the Cooperative Call Center. Daily, Erica manages provider credentialing, care coordination, and annually submits HEDIS quality data. Erica, I'll now turn the floor over to you to begin today's webinar.
Thank you so much, Emma, and thank you everyone for taking time out of your day to come to this seminar. So what I really wanted to talk about was how us here at Group Health have really started an entire quality improvement program in the last 2 years from the ground up. We really started to realize that there were gaps in care that our members were experiencing. We received a lot of feedback from them, and in working with providers, we decided to partner together to really ensure that patients were receiving all of the care that they needed. Here at Group Health, we are actually located in the western part of Wisconsin. We were founded at about 35 years ago and are an HMO-style health payer system. One of the biggest things that we pride ourselves on are really the focus of everything throughout our day are our members, whether it be answering phones live, to troubleshooting any member issues that come up, to coordinating care with providers and helping them in any of the issues that they may be experiencing as well. In starting with quality, where we really wanted to start was with HEDIS. It really has laid the groundwork for most of the quality initiatives that both health plans as well as healthcare providers use when they're looking at quality measures. Over 90% of the health plans throughout the United States actually do report for HEDIS, and it incorporates a lot of measures, 81 to be exact for this year, and there really is a broad range of issues from pregnancy to child immunizations to mental health to utilization overall. So it really lays the groundwork of where we wanted to start as far as putting together a quality improvement program. So in taking the first steps, what we really needed to do was look at our areas of focus. One of the areas, of course, is looking at company goals and values. We also have a pay for performance program when it comes to our Medicaid block of business. We have star ratings that are important for our commercial side. We hear feedback from members throughout the day in our various departments. And also we look at utilization. Where are members going? Where are high utilization? Where maybe there is low utilization? Here at Group Health Cooperative, really our purpose is optimizing the health of our members. And something that you will notice is we do not put health care because we really feel like there is more to members than just their health care. It's their overall health and well-being. And a lot of times with that, we will talk about later, is all of the social issues that may be going on in members as well that really is affecting their health. Next, we thought, okay, we have star ratings. Many health plans have star ratings involved, especially if you are in the Medicare side of things. So we thought, okay, well, high compliance when it comes to HEDIS typically means a higher health rating. And after that, you can really kind of make an argument that that leads to higher enrollment. For us here at Group Health, our commercial block of business really incorporates the northern half of the state, and you can see that in here. So big range of demographics, lots of different needs when it comes to commercial side of things. Then what we decided to do was we have a pay for performance program. This is for our Medicaid block of business. So in Wisconsin, that includes our Badger Care as well as SSI. People qualify for Badger Care due to low incomes, where SSI is related to members who have either physical or mental disabilities. There are certain goals that our health plan was told we needed to meet as far as compliance goes. So we thought this is kind of a natural thing of where we also need to make sure that we keep in the back of our mind that this is extremely important. We have a lot of dollars that are tied up in ensuring that we meet those compliance standards. So we knew that we needed to make sure that we focused on this as well. For our Badger Care line of business, which is the bulk of our coverage here, we really do cover almost the entire state of Wisconsin. It's good and bad. We have a large membership, but also, as you can probably also assume, that it leads to a lot of differences in members and what they need. Lots of different backgrounds, lots of different access issues, and from a customer service side, that also means that all of our members may need something different depending on where they live. What we need to provide to them is going to be different solely based on where that they reside. A big thing that we also make sure and is always at the forefront is when we're having conversations with members, we want to make sure that we hear what they need. What are they experiencing good? You know, maybe they received great service at one of our providers. Maybe they are confused about some of the services they received. Maybe they're unhappy with services that we at the health plan are able to provide them. So we really wanted to make sure that we're hearing what our members are saying. And some of the big areas that come up are pregnancy. Women oftentimes get confused. They're not sure about all of the care that they might need, not only for themselves, but with their baby. Medication management. A lot of our members are on multiple medications. So 5 or more is something that is very common with us. And with that comes a lot of members who have side effects. They don't always know what they're taking, how many times to take it. They forget to take medications. So we wanted to be able to make sure we kept that in the back of our minds as well. Childhood immunizations is one of the topics that all across the country we're seeing a lot of feedback as far as are people getting them? Are people not getting them? There's been a lot of outbreaks, specifically in our area, over in the Minnesota, St. Paul, Minneapolis area, there have been numerous outbreaks. And a lot of confusion comes along with immunizations. There's a lot of information out there, and we're getting a lot of feedback from members on just sheer confusion. And we wanted to be able to say, okay, what can we do with that? How can we help them be less confused? How can we partner with our providers, who I'm sure are hearing the exact same feedback? How can, between the two of us, we make sure we have some kind of impact? Emergency room. As you could see from our coverage map, we have a very big footprint, and with that comes a lot of emergency room usage. There's a long drive sometimes that people will have to make between where they live and their closest primary care clinic. And with that means people are probably going to end up going to the emergency room more often than what we would like to see. That's something that's common in other areas as well. And we really wanted to make sure that we would be able to help members and educate them on, here's some things where you could go to the emergency room, and provide them options for not going to the emergency room, making sure they get established with a primary care doctor, making sure that they're happy with their primary care doctor and that they're receiving good communication back and forth. And also letting them know about urgent cares. There's a lot of urgent care clinics throughout the country. We want to make sure that they're being used. They're there for a reason. And a lot of people just forget about urgent care clinics. And maybe there are other options. Maybe there are telehealth services that members may be able to be using instead of physically going in somewhere. Is that an option? A lot of times members are not able to physically get somewhere without having to plan ahead of time, talk to a friend, see if they can take them. And in the middle of the night, it's a challenge too. If you are a mom and you have other children at home, to be able to pack up everyone and go to the emergency room and potentially wait for some time before being treated. That's not something that's good from a member side as well as from the provider side. They also want to make sure that they're providing adequate care to their patients, and they want to make sure that their patients are being taken care of. And sometimes that means not going to the emergency room. Another big thing, which is going to be our focus today, is specifically on mental health. When it comes to inpatient as well as outpatient, there are access issues for many, many people. And we wanted to make sure that, especially when it comes to mental health, typically there are a lot of other social barriers that members are facing. And we decided to really take mental health and really face it head on and see what we can do as far as putting together a program on mental health to make sure that members are getting all of the counseling they need, all of their medications that they may need, and also helping out the support systems they have at home. So many times it's not just about that individual. They are going through a lot of things at home, and we want to make sure that that support system is there for them. And many times, as you'll see later on, is that support system might be a provider, it might be their doctor, it might be a nurse, it might be their counselor, it might be someone here at the health plan, one of our case managers or care coordinators, who is really simply listening to them and really just being able to help them with day-to-day life that they're just not able to handle on their own. So after looking at all of the different areas, we thought, okay, what can we do as far as getting data available? A lot of things you can talk about anecdotally of a lot of people are going to the emergency room and a lot of people are upset. But when it comes down to it, you want to be able to quantify that somehow and be able to direct your care towards people. And for finding that, there are a lot of different ways you can do that from a data perspective. If you have EMR systems, a lot of times you can get the data out of EMR systems. If you don't have access to EMR systems, like many times on the payer side of things, you obviously have data from claims that you're able to provide queries and get access to. There are also a lot of different software options out there that you're able to get that information from too. And a lot of times those software systems can be specific to HEDIS. So a lot of times it will do it for you and you're able to get the members that you are really trying to focus on. And that is what we do a lot of times in addition to doing claims queries. That is, we really need to find out which members are being effective and how they're being effective. Is it overutilization, underutilization? Is it somewhere in the middle? Are there a lot of ER usage issues? Are there no mental health follow-up issues? Why is that? Is it because there's just not an adequate network? Are members not showing initiative and going in? Is it a fact where providers are just full? They just cannot take on any more patients as far as cases goes. And a lot of times it's kind of a combination of all of that. So many times you can take the HEDIS data and get it down to a specific topic of interest. And specifically, you can get it down to any of the HEDIS ones that you would like. And for us, we focus a lot on the mental health side of things. So we can truly see which members are affected and which members have both gotten the care that they need and which members have not received the care that they potentially might need. And what we're able to do then is we're able to extract all of that data, find which patients are not receiving care. We're able to coordinate with their primary care doctors to make sure that between the two of us, we're able to get members in for their appropriate care. Providers appreciate the feedback. They too, a lot of times, are trying to get a hold of members. It's hard. It's very tough to get hold of members and make sure that they feel empowered to do self-management on their own and be proactive about their own health. And we have found as a health plan that by partnering with providers in bridging those gaps in care, it really does help members because they really feel like both areas are looking out for them. You can have a lot of stereotypes about doctors not wanting to see patients and health insurance companies not wanting to pay for anything. But by really forming this partnership, we've been able to make drastic improvements in our quality measures. And that's one of the most important things that we've seen is you can't do it on your own. As a health plan, you cannot think that you're going to be able to get all of the members in for all of their follow-up care, for all of the gaps that they have in services without the help of a provider. And the same way on provider side. They really need that extra help. They have a lot of initiatives going on their side that by being able to partner with us, they're also able to get a hold of members in a better way. And sometimes they can't get a hold of members at all. So by us being able to help them out, it really is a wonderful partnership that we have been able to build together. So we've got the data. We kind of have an overall idea of what areas are important to us. And the next thing what we did is we really talked to a lot of people involved. We got providers on the phone. We had in-person meetings with them. We talked through the process. We talked about what areas that they were seeing that members were struggling with. What are their challenges on a daily basis? We talked with our staff internally as well. We made sure to get everyone involved because everyone has a different perspective, everyone brings a different viewpoint, and everyone kind of has a little bit of knowledge that by combining all of it, it really was wonderful and able to, for us to make a great quality improvement program. So on the clinician side, we got doctors as well as nurses involved. We got providers involved from not only just a doctor standpoint, but we got administrators involved. We got our customer service team involved. They hear from members as well as providers on a regular basis about issues going on. We had to make sure that our contracting and network team was involved. They're on the ground. They're talking to providers on a daily basis and hearing things and hearing stories. We wanted to make sure that we had their perspective in mind. And then from a data point, we got our IT department involved. They know the data. They're able to get whatever information we need. And we wanted to make sure that we had an analytical team involved too. They can look at the data and really be able to provide areas where they feel might be somewhere for us to look at. So it's really getting everyone involved, getting opinions of everyone. Open communication has worked wonderfully in this entire process. So in putting together a plan here at Group Health, what we really wanted to focus on was mental health. We figured that was the challenge that was probably the most difficult one for us to start with, but we knew if we could figure out a successful program when it came to mental health and ensuring members going in for follow-up care, we could apply those to other areas as well. Access is always an issue for mental health for many reasons. There aren't enough providers. The ones that we do have are incredibly busy and booked, that sometimes it just takes a while for members to be able to get in for care. And on the opposite side of that, members don't always go in for services that they need. There's still, unfortunately, a stereotype when it comes to mental health that members are nervous getting help for care. They don't know who's going to see them. Are they going to be judged? So we wanted to be able to address the access issues that there are throughout our communities. And one of the big things that we have implemented over this past year is telehealth. Telehealth is one of those areas that is developing really nationwide. And one of the things that we have noticed is that with telehealth, members are a little bit more comfortable being able to have conversations. Sometimes having that in-person discussion is a little hard at first, especially if you're uneasy about your current situation and whether you want help and what kind of help you should get. So we really wanted to be able to provide an option for members to have telehealth. And in that, if they are doing telehealth, make sure that at some point they know they can transition back into really in-person care, maybe group counseling appointments when they're ready. The other big issue that we see across the board are social barriers. It's one of those things that we probably in the last year or two really find more and more prevalent is us dealing more with finding resources for people on the social side of things. It's not always addressing their medical needs up front. A lot of members have issues with housing. They either don't have a place to live at all, or maybe they don't live in a safe place. And without knowing where you may be sleeping that night, you're not going to be wanting to go in and getting counseling appointments. Your immediate need is housing. Where am I going to live? Where am I going to be safe? Other social issues that we deal with here at Group Health include transportation issues. Transportation is huge as far as people not always having stable transportation. So we're able to coordinate to make sure that members do have transportation. We schedule transportation with them to make sure that it does happen. And also we follow up with them, just reminding them of their appointments that are coming up. Day-to-day life can be extremely overwhelming. And sometimes you just forget about those appointments if something else comes up. So we want to make sure that members are remembering of the appointments that they do have. Sometimes members struggle with food. They maybe don't have any or don't have enough. And we want to make sure that we address those needs with members as well, instead of just solely focusing on, you need to go to the doctor, here's your time frame, you need to get in, make sure you call. We really feel that by building that relationship with patients, that we're able to build that trust factor, and then they will go in for their appointments. And when they do have questions, they're more apt to call and just say, I'm confused about something. Can you please help me? Can you help me with making an appointment for the doctor? I don't know the number. I'm too anxious to call. I don't know what to do. So it's really on the social side, it's really about surviving, and then they can thrive. Get their day-to-day struggles in order as much as we can, and then we can help them to make sure that they can feel empowered to improve their health and well-being. A next area that we really wanted to make sure was staffing. We literally started from the ground up about 3 years ago in our quality improvement department, and we wanted to make sure that we had individuals focusing on these areas of quality and that were passionate about those areas in helping members. We did have a lot of these areas wrapped up in our normal case management program, but we really found that a lot of these issues needed to be more at the forefront. And in order to do that, we wanted staff where solely they were working on many of the HEDIS quality measures to ensure that people were going in and we were able to form those relationships with them. And in order to do so, we really wanted to have the needed staff in those areas that really are passionate about members, that are sympathetic to what they may be going through. And for us here at Group Health, that meant not necessarily them needing to have a medical background for an RN, an LPN, a CNA, anything like that. It was really that customer service background that we were looking for and that we have ended up hiring in that area, because it's really about that customer service. If we do find that a member has multiple health needs, we absolutely will fold them over into the case management program where our RNs will follow up with them on a more intense level. But for many of the things that we are facing when it comes to simply making sure people are getting care and going in for quality care, we really found that customer service was key. And making sure people were passionate about that was really what's most important. So just to give an example of specifically our mental health program, is we wanted to make sure that we were continuing to see that growth in compliance. When we started out back in 2014, we were doing okay, but we weren't meeting a goal that was provided to us for our pay for performance program. So we were really being penalized for not being compliant. Shortly after the Pay for Performance program started, we received a huge influx of members, and that is why you can see the drop in compliancy in 2015. And it was really at that point where we said, we need to make sure we get a program in place. We need to get a telehealth component going. We need to really work in partnering with our providers in making sure that all of these quality areas are addressed and make sure that we see improvement in that. And after that, in 2015, you can see that we have continued to grow in our compliancy with counseling. And a lot of that has come with having that partnership with our mental health providers in doing whatever we can to help them along in the process as well as being able to help our members go in for care. And actually, as of right now, we have gone over our 15% for compliancy rate, which we are absolutely ecstatic about. And it is actually for both of our lines of business, which we haven't seen in the past. So it really has been a long time coming. It really is not something that can change overnight. And by that continuous outreach that we have with members, that's where we're able to see the growth that we have in compliancy specific with our mental health program. I wanted to share a couple of cases that really have touched us in our department over this last year so you guys can really see the different scenarios that this may apply to, especially here at a health plan. It's not always common for us to share success stories. We hear it a lot on the provider side, and we are absolutely thrilled every time we hear that. But just to give you an example of how our mental health program has really grown and touched a couple of our members' lives. So this past spring, we were actually introduced to one of our members named James. He is in his early 50s. He is part of the Medicaid program. He has no spouse, no family nearby. He really is on his own. He clinically has a history of alcohol dependence. He has anxiety and depression, chronic pain. He is a type 2 diabetic, and he was actually, unfortunately, attempting suicide, and that is how he triggered in our system as far as needing help. So in March, he actually attempted suicide the first time. We attempted to reach out to him multiple times after he was discharged from the hospital. We could not get a hold of him. He would not return our phone calls either. Unfortunately, a short time after then, he was going through a tough time again. However, this time, he actually reached out to us here at the health plan. And he reached out to one of our care coordinators saying he had received our letters in the mail, he had received our phone calls, and at that time he wasn't ready for help, but now he was. He hadn't left his home. He had not talked to any family members or friends. And he, at that point, was talking about actually overdosing on his diabetic medicine. And at that point, our care coordinator got him taken to the hospital. We had called 911. The cops came. They took him to the hospital and made sure that he was taken care of there. While he was in the hospital, we actually did multiple attempts to him to check up on him to see how he was doing. We didn't want to break that relationship bond that we had clearly formed just by all of our attempts to reach out to him. Now James is actually doing wonderfully. He is going to weekly counseling sessions. He is actually going by using the bus. He was severely anxious, did not want to talk to people, did not want to go out in public, and we were able to, after him receiving help through counseling, he's now able to take the bus to his appointments instead of walking on his own. He's making sure he takes all of his medications. So he does all of his medications on a regular basis. He's getting physical activity. He goes out, he exercises, he walks to the park. He is able to do all of that. And one of the big things and most things that we're proud of here is he actually has interviewed for a couple of jobs now. He feels like he has been empowered by all of the help that we've provided, as well as the counseling that he has received from our providers. And he is really ready to make a change in his life. And I think that's the most important thing for James, is between all of the providers that were involved in his care, as well as us here coordinating that care, we really did save James's life. And we are so proud of James for everything that he has accomplished in the few short months that we have been managing his health. He will randomly call us and just let us know what's going on in his life and make sure that he's okay, because we do worry about James every once in a while, but he is absolutely thriving. A next member that I wanted to share was Sherry. Her situation is a little bit different. She is in her early 50s, but she does have a support system. She has a husband as well as 2 adult children at home. She also has a history of chronic pain and alcohol dependence. And we were notified of Sherry because she actually has gone into detox multiple times now. And last December, she attempted detox for the first time and left AMA. We attempted to reach her. We attempted to have follow-up care scheduled for her. She wouldn't go. She would schedule some and then just be a no-show. She would also schedule appointments and then cancel them a short time later. Then in May, she actually went into detox again and again left AMA, unfortunately. We did multiple attempts to try and get a hold of her. And actually one day we were able to get a hold of her husband, who was answering the phone and taking care of her on her behalf. They at that point said that they were again ready for her to try a detox program. We actually got her into a different program than she had tried previously. We thought that might help in making her successful this time. We got her into the program, and we also reached out to her on a daily basis just to show support for her. And in addition to calling her, we actually made sure to reach out to her husband as well. We could tell that he was struggling with the situation and was enabling her as well when she wanted to leave detox early. So we made sure that he got in counseling. So we wanted to make sure he had the skills he needed to be able to assist her. And in doing so, this final time with detox, she was able to fully complete the program. It was not easy for her, and there were a lot of days where she did not want to stay there, but by the coordinated efforts between our care team here as well as the wonderful staff at the detox facility, we were able to calm her down and walk through the entire process. We were able to talk with her husband, make sure he knew what the plan was for her. And by coordinating all of that between all of us, we were able to make sure that she completed her program. For her, we have checked in with Sherry, and she continues to be sober since June. She is continuing to go to weekly counseling sessions, and she has recently, as of a few weeks ago, started group therapy as well. She also attends local AA meetings when she can to get that additional support from peers. The biggest thing is she's continuing to take her medications as well. That seems to be kind of a common thread throughout many of the cases that we see, is for various reasons, people are inconsistent with medications. One of the things that Sherry has also done to continue her growth is she's quit smoking. She decided she was able to make the change with alcohol, and she really wanted to continue to be healthy for herself, her husband, as well as her kids. And now Sherry, as well as her husband, are going on a regular basis and enjoying open mic nights. They're able to go out and be active in the community, and she really has made a really big change, and she's stuck with it, and we are extremely proud of Sherry as well. So obviously this has not been easy. It has been a long road, and nothing ever really seems to go as planned. But a couple of things that we just wanted to note was this truly is a marathon. This was something that has really been almost 3 years in the making for us, in making sure we build those connections, not only with our patients, but with providers as well, making sure we continuously have communication and are continuously providing that feedback back and forth between all areas. Flexibility and adaptability. We wouldn't have been successful if we would have had to stick with a program for a long period of time, even if we were seeing it wasn't working. We really needed to be flexible, not only on our side, but as well as the provider side. We knew that going out of the gate, there wasn't a magic pill. There wasn't that golden ticket saying this is absolutely the right way and it's going to make everyone compliant and everyone will be happy. We knew that along the way we needed to be able to make changes, and we needed to be able to make changes quickly. Otherwise, it would add on to that time frame of being able to see change. And that was something that we really wanted to be able to, as quickly as possible, see changes. And if it wasn't effective, we needed to be able to move on and try something else. And finally, passion. All of us love our members. We all do, from a health plan perspective, from the provider's perspective. We really want to see patients succeed. And I think that's the biggest lesson that I've learned in all of this is if you're passionate about what you're trying to convey to patients, they'll really start to see a trust in you and realize that you're just not in this to earn money or to save money. It's really about them and making sure that whatever they might need, that we're able to either solve that problem or be able to provide them resources so that we can get that problem solved. And I am very lucky. I have a wonderful team on my quality team who is passionate about everything related to members and what they might need, as well as others who are wonderful at having that communication with providers who have that background from working in a facility, who know how the system works there, where we can really bridge that gap between the two of us to ensure that members are receiving the care that they need and making sure that it's appropriate care as well. So a couple of things as far as success that we have seen for everyone to review is it's really about lowering costs. Now, that doesn't necessarily mean that we are eliminating ER usage and all of that is going away. It's really making sure that members are going in for appropriate care. So while we may see utilization go down in an ER perspective, we'll see utilization then go up in other areas, such as the mental health counseling, such as primary care. So it's really not eliminating costs, it's really just shifting those costs elsewhere. And from a quality standpoint, providers have been extremely happy with the added help in managing patients. Sometimes patients, as we know, can be extremely difficult and stuck in their ways, and knowing that there's two of us really on the same page trying to figure out a way to get to that common goal has been absolutely wonderful. And knowing that at any time we're able to reach out to providers and have them know of a situation with a member, be able to provide help with that has been wonderful. And it's really also increasing efficiencies. We are able to now make sure that members are receiving the appropriate care that they need, bridging those gaps, lowering those instances of members being non-compliant. And that's great on the provider side as well, because we're not necessarily seeing that huge backlog of members needing to go in. Now there's going to be a large time frame before they can get in because they haven't been established, and that takes extra time. So it really has been great to see that connection with making sure members are going in for care And then throughout the entire healthcare system, it just makes it easier for everyone involved. So at this time, I would like to end my presentation, and we will open it up to questions. So Scott is going to be leading that specific area.
Erica, thank you so much, and what a terrific presentation. We've got a ton of questions. I'll try and sort through them and ask you. The first question is, personal responsibility of patients. What have you seen or strategies that you've used that have been successful in implementing or encouraging personal responsibility in the patient?
You know, that is one of the things that we struggled with most, especially in initial engagements that we have with members, is they seem to say, well, my doctor will just tell me if I need something and just leave it at that. But we really wanted to make sure that members are completely understanding the big picture of, if they don't go in for something, these are the things that happen. And it's not necessarily up for the doctor to continue to remind you of services you need. You need to be able to care about your health, to feel empowered about being able to do something about affecting your health in a positive way. And a lot of times it really does take time, and it takes time building those relationships. Providers see that over time as they continue to see members, that trust begins to grow. And it's the same thing on the health plan side. As we continue to talk to members, see what they need, we really make small goals for them. It's really not just to tell them. It's really, you have to make a goal, make it something that is obtainable. And then the next time after they meet the goal, slowly add another one in. And then before you know it, they're really being proactive about their health.
Gotcha. Who at the health plan is interacting with the patient on these issues? Who sort of is it? What team is doing that?
Really, it is a combined effort between our health management and quality teams. From a daily basis in ensuring members go in, that is something that our quality team, which is full of care coordinators, does. They reach out to members, they let them know what is missing, they help schedule appointments, they help schedule transportation, they troubleshoot as far as where members can go to receive care. If it's something where a member really has a complex medical case and really needs more assistance on the medical side of things, we then transfer the case over to our case management team. So a team of RNs will then follow up with the member on a more intensive level.
Okay, got it. Thank you so much. What's the impact been with ER diversion in the triage of behavioral health and substance abuse assessment and treatment? How has that gone, and how is that responsive to HEDIS measures?
Sure. When it comes to ER utilization, it is one of those things where a lot of people with mental health conditions unfortunately present at the ER. It's one of those things where you can't always prepare for a mental health episode. They are triggered by multiple things throughout everyone's days. So what we're able to do now is, once somebody does present to the ER for a mental health condition, providers are notifying us of those occurrences, and we actually start reaching out to the member right away, whether maybe they're still in the ER, maybe they got transferred over to an inpatient facility, or potentially they were treated and sent home. By contacting members as soon as possible, we're able to really curb their behavior, because a lot of times they just don't know and aren't able to prepare for things. So as soon as we can reach out to them after an instance has occurred, we're finding the better. We're able to educate them right away on their different options and help them get in for counseling appointments to hopefully prevent them from the next time going into the ER.
Gotcha. I've got a number of questions that relate to sort of cost benefit, ROI, what this cost, how and so forth. So let me start with, have you had reduced cost? Have these efforts led to reduced cost of care? Has there been sort of an ROI on the effort?
Sure. Overall, we have seen a slight reduction in cost of care. We're now a couple years in, and very much like I had alluded to before, is We didn't go into this thinking we were going to be able to make a huge difference from our perspective on reducing ER costs and costs in general. We knew that it was going to be more of a cost shift in seeing those services being done at an ER type situation, being moved over now into more of a primary care scenario. So from our perspective, that was really what we were looking for, is we see a lot of ER utilization and all the various costs that go along with that. Can we shift some of those costs now over to a primary care or mental health type situation? And with that means they go in for primary care more often, they go in for more mental health counseling appointments. So we didn't completely eliminate the costs, but we're able to see a slight reduction just because it is less expensive to go in for primary care and mental health counseling than going into an ER.
Yeah, absolutely. Let me ask you a different question. I'll come back to another dollar question. Have you been looking at collecting data on social determinants to better target and predict which people might have need or which people you need to reach out to?
You know, it's very hard on the social side of things. A lot of times you can't necessarily predict. You can kind of get a general idea based on seasonality. A lot of times, you know, depending on what time of year, we do see specific trends that are going on, especially living in Wisconsin. Obviously, it gets colder in the winter, and there's a lot of issues that come along with that from a housing and heating perspective. So we're able to predict those. We've also taken a look, especially demographically, in specific areas. We are not urban in any way in the members that we cover, but we are able to see in certain pockets, maybe where there are certain economical issues that members are facing. So we're able to prepare a little bit more when we're doing outbound calls to those. But overall, it's something that's really hard to predict, and we're definitely still trying to capture as much information as we can from a data perspective in order to be able to predict a little bit more what members might be needing and that anticipation that goes along with that.
No, thank you. And then how did you find the dollars and resources to cover some of the QI teams, some of the nursing teams, some of the staff, the care coordination, as well as some of the other social needs to the extent you're providing some of those? So where did you guys find the dollars internally to fund a lot of what you're doing?
Sure. A lot of it was really cost shifting. So we really took a look at a high level organizational level where we needed to really prioritize. And a lot of that came down to making sure there were appropriate resources within the health management department. A lot of times it's easy to think maybe more of a call center perspective. Well, they can answer questions, they'll be able to field things, it might be easier. But when it got down to it and what we really wanted to do as far as an initiative goes, we felt that on the health management and quality side of things, that's where we really needed to make sure we had the right people in place, that they knew the common goal of the overall organization as well as what our team goals were. And we were willing to put in the resources there, knowing that along the line, costs would eventually start to decrease. We would see increase in enrollment because of all of the different initiatives we were doing. We would be able to partner with providers so that they knew what we were doing from a health plan perspective, so that they could say, hey, group health is doing wonderful at this, thank you for everything. And then us as well, being able to really see where members are going for care and being able to say, hey, I know at the clinic down the road that this is what they're able to do for you. Let's get you partnered up with them. Let's get you scheduled.
Sure. Let me ask you a question in terms of the size of your QI team. Can you give a sense of that? Is that something you can give a sense of?
Sure, absolutely. Overall, our organization covers about 75,000 members. And with that, specifically on our QI team, we have currently 6 individuals who are continuously all day long on the phone talking to members. And that's really what their focus is to be proactive and reach out to as many members as they can. Each of the individuals within the team kind of have a specific area that they really like to focus on. So I've got a group that specifically loves working on mental health and loves being able to help those with those particular needs. I have a couple others where they love working with women and children. So that's where we've kind of put them as far as initiatives go.
Got it. Okay. And the members that are, one of the questions we have is on patient attribution. And a provider is saying they often get lists of patients that may have issues or patient attribution issues. And, often they'll get a list, and the patient list is, is not, and this is not a group health issue. It was more said about managed care generally, that there's so many errors in the list or wrong people on the list that it becomes a not as helpful a tool as it could be. Any thoughts or comments on that issue of sort of, and I've seen some of these before, are there ways to reduce the amount of sort of errors on that list that are sent to providers? And are you in that area? Are you working with that where you're sending lists to providers?
Yep, absolutely. And I completely can understand where providers are coming from. When we first started our program, we were in a very similar situation. Received a lot of feedback that they're getting lists and they haven't seen that particular patient in years. And once you start sending those lists on a regular basis, the list really didn't become useful in any way. And the most important thing that I can say with that is to make sure you have that continuous feedback with the health plan. A lot of times, if members aren't going in for any type of care, you really rely on, well, who was the last one they went to? Maybe they have some type of contact with them that we don't know about. We don't have a claim received on them. So it's really important to provide that constant feedback between the two organizations. By doing that, we've been able to improve the list. They are in no way perfect. We definitely still have areas to improve when we do provide lists to providers, letting them know which members might need care. But it has gotten tremendously better since when we started, and it really was having that feedback, working with your technical teams that you have in fixing those areas of attribution.
Sure, gotcha. So it's an ongoing effort and very familiar, obviously, and a constant battle to try and improve, is what I hear. So there's a question as follows, Erica. With cost shifting, is there an interest in using peer model of services to increase the warm handoffs of patients and improve engagement in resource building with patients? Is there that interest? Is that
we do as much as we can on our side as really being able to have that handoff between our organization and the providers. And then at the provider level, we actually speak daily to physicians, to nurse practitioners on the individual member's case to see, are they the appropriate person for treating that member? Is there maybe somebody else? And doing those handoffs then to say, Dr. X isn't appropriate. Let's get them over to this one. I'm sure they can help with counseling or medication management better. They're a specialist in that particular area. So we absolutely love to do as much as we can as far as partnering together to transition members wherever they may need to go, even if it is out of a particular clinic system. If another one is potentially better or more specialized in that area, we're happy to help facilitate that process as well.
Let me ask you a question also deals with transitions or touch points. The touch point between your services and the electronic medical record. Do your services touch the electronic medical record or not, or how does that work?
Ours actually does not. We are, in our particular area, we are not able to share information with providers through an EMR system. So if there is any type of communication that needs to be had, we are happy to pick up the phone and talk with any type of provider out there. Or of course, we can email information back and forth as well to really ensure that both places understand the big picture of what's going on with the member.
So it's still a very high-touch effort with care coordination, your nursing staff, your QI people, and so forth.
Absolutely.
Fair statement?
Fair statement.
And so another question about net cost savings, and this came in a different way earlier. The reduction in spend, and I know you had mentioned, this wasn't really so much about reduction in spend, it was better care, shifting costs to the right spot, trying to reduce ER use, and just improve how care is delivered. But can you look at a net cost savings when you look at the amount of care coordinators, technology, et cetera, that you've put into the program? Is there still a net cost savings, or is it more neutral at that point, but still beneficial in terms of improving the quality of care and the stickiness of group health with its members?
Absolutely. We're at the point now where we're able to see some of the cost savings come into effect, but it has been a long process to get there. It's been a couple of years before we're really starting to see those types of cost savings. And it really comes down to, we knew that it wasn't going to be an overnight change, and we weren't doing this knowing that our end goal was to save money. That really wasn't the whole point of setting up our QI program. It really was, we saw a need with our members and we wanted to be able to help in some kind of way, and we came up with this program. And one of the benefits, of course, is absolutely reducing costs in some areas, but that wasn't the main goal when we put this program together.
No, and that's a great answer. You realize it was an investment in better caring for your members, better coordination with your providers, and it still turned out that over a few-year period, it has started to generate a net cost savings, actually. But it was, the first goal was, you knew you were investing in this and hoping not to lose too much money on it, but then have actually found savings over time on a net basis. Fascinating. That's great. I have got dozens more questions, so I'm trying, Erica, to pick one or two more so I don't keep you on the phone for another hour that we've got from people on the phone. Let me ask you the following. What's been the reaction from your providers on your efforts with this, whether from a mental health compliance standpoint or just generally in bridging the gap in patient care? Have your providers been responsive to this, resistant to it? How have they reacted to group health efforts in this area?
Sure. Initially, when we started talking with our providers about this particular program that we had wanted to put together, there was that resistance. I think they, initially thought the reason we're doing this is to save money. And by explaining the process really with them, they were able to see that it wasn't about the dollar from our perspective. It really was about the patient perspective. And I think they can appreciate the challenges that go along with contacting members and getting them in for care as well. And at the end of the day, with being able to partner together, we knew that the end goal was really to make all of our patients healthier. And in a sense, we couldn't do it without each other's help. We really needed to rely on each other in order to make sure we as a health plan were doing everything we could, and then communicating that back to providers and having them provide us education. If we were overstepping, if we weren't doing enough, we're happy to hear that feedback and make adjustments if we feel that's something that is necessary. But the important thing is, by having those conversations ahead of time and not just letting them find out along the way, it really helped a great deal. They really felt like they were part of that process.
Gotcha. So you guys did a lot of communication up front with your providers, so they weren't surprised when they started to hear that you had a care coordinator or a QI initiative or team involved. And that was helpful in softening this sort of, or helping to improve communications and transitions and so forth. So fantastic. Erica, I want to do this. I want to thank you. Just a wonderful webinar. It's our favorite type of webinar where somebody spends an hour educating the audience and does virtually zero selling of any services. I want to thank you profoundly. I also want to thank Change Healthcare. Change Healthcare is the sponsor of this, and I'm always thrilled when one of our top sponsors uses the hour to fully provide education to listeners and attendees without selling. So my profound thanks to you a great presentation. People stayed on the entire time, at least until I started asking questions. When we lost you was when I started asking questions. And also I want to thank both you and Change Healthcare just tremendously. So thank you very, very much. I'll wrap up to respect people's time that we're at 2 o'clock. I know that between Change and yourself, they'll help look at some of the follow-on questions and see if some of them can still be responded to. But just a wonderful presentation. Erica, thank you so much, and thank you to Change Healthcare. Thank you.